Jeanette Bean is originally from Michigan, where she was raised as the 12th of 14 children on a blueberry farm. Wow, that's a lot of siblings.
Yep. Big
After receiving her bachelor's degree in pharmacy from Wayne State University in Detroit, Jeanette earned her PharmD from the University of Florida. She has more than 20 years' experience as a clinical pharmacist, with several years focused on post-operative pain management. She is currently the pharmacy operations manager at St. Mark's Hospital, where she is responsible for the day-to-day operations of the inpatient pharmacy, ensuring that patients' medication needs are met. She also leads the pharmacy technician team and manages team members' performance growth and career development. Jeanette believes that no task is too small, nor any job too big to be completed. Patient-first focus. Jeanette enjoys spending time with her family and friends, hiking, cooking, and reading mindless works of fiction. She's crazy about animals, which she blames on being raised on a farm, and currently has a dog and 2 cats. I will let Jeanette take it from here.
Thank you very much. I'm happy to see everybody here online today, and we'll just go ahead and get started. And when we get to the end, I will save time for questions. So if you hold them to the end, that would be easiest. You can put them in the chat box as they come up, and we'll get to them at the end. Thank you. So today we're going to talk about opioids, the risks, dangers, and benefits. And it's a topic that I think we've all heard quite a bit about in the last few years. So we're just going to go ahead and dive right in. So what are opioids? Opioids are psychoactive substances derived from the opium poppy or made synthetically in a lab. Whether they're naturally derived or they're made in the lab, they have the same effect in the body. The term opiate is used to describe the natural or opium-derived products, and opioid refers to all of them, whether they're natural or synthetically derived or man-made in the lab. So what are some prescription opioids? There's several different brand names and lots of different generics, but some of the more common ones are hydrocodone, and some of those brands are like Lortab, Norco, so Hydro. If you're from back east or the Midwest, you're probably more familiar with the name Vicodin, but those are all hydrocodone products. There's also oxycodone, and some brand names or common names of that is OxyContin, Percocet, and Endocet. There's also morphine, which comes available as a tablet or an IV medication, and brand names of that are MS-Contin, Cadian, and then several other names as well. Codeine is also a prescription opioid, and it's most commonly found either in cough syrups or in Tylenol number 3, which is Tylenol with codeine. And then there's fentanyl, which has been in the news quite a bit lately with the illicit drugs, but we'll talk more about that later. And brand names of fentanyl are Duragesic, which is a patch, and they use that for chronic pain or more like cancer-related pain in general. And then it also comes available as a product called Actique, which is more of like a lollipop or lozenge that you suck on. What are non-prescription or illicit opioids? Those include things like heroin, opium, designer drugs. And right now, most of the designer drugs that are out there are fentanyl analogs, which basically mean they're like cousins to fentanyl. And they're drugs that are made in the lab, and they're just very similar to fentanyl in structure and in action. These designer drugs often originate in foreign countries, and then they get brought into the U.S. Either through drug mules or people bringing them across the border, or being purchased online and what they call the dark web, which are basically just illegal websites, and then mailed in or brought in that way. An example of that many of us might be familiar with was the street drug they were calling pink. And that was a medication, not medication, sorry. That was an illicit drug that led to a couple deaths in Park City in 2016. And then one thing that a lot of people don't realize, a prescription opioid, that is not your prescription. If it's somebody else's and you have it, that is also considered illicit because it was not prescribed and does not belong to you. So the reason people are interested in opioids, or the reason most people have any knowledge or experience with opioids, is because of pain control. So we're going to talk a little bit about pain control and pain in general. So what is pain exactly? Well, in 1968, a person by the name of McCafferty defined pain as whatever the experienced person says it is, existing whenever she or he says it does. In 1979, the International Association for the Study of Pain introduced the most widely used definition of pain, at least as far as in terms of medicine goes. And they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So a little bit more about pain, and from that definition, we can understand that pain actually has many components to it. You have in the pain pathway, you have the physical cause of the pain, whether it's a burn or an arthritic joint or whatever. So that's the source of the pain, and that sends a signal through your peripheral nerves to your spinal cord or your central nervous system. And then from there, it goes to the brain. And your brain interprets that signal as pain. And then our thoughts and our emotions also play into how we perceive that pain and how we feel that pain. Interestingly, there's cultural differences in the way people experience pain. And we won't really get into that, but that just helps, or that just further proves the point that our thoughts and emotion definitely affect our perception or our experiencing of pain. So this is just a little meme for kicks and giggles, I guess. And it says, "You're having pain? False. What you're experiencing is simply electrical signals that your brain is perceiving as pain." And important to remember is everybody experiences pain differently because of the thoughts and emotions, their brain's perception of the pain and what it means to them. Since pain is very dependent on our brain, or our brain processes those signals and tells us what we're experiencing and how we're experiencing it, we'll talk a little bit about how opioids affect the brain. So when you take a opioid medication or a pain medication, narcotic pain medication, whatever you want to call it, that medication gets metabolized and into your bloodstream, and the opioid binds to and activates receptors that are located in many areas of the brain and in our spinal cords. The opioid binding to that receptor blocks that receptor's ability to send the signal. So it's kind of like in the old days, if you had a party line on your phone, and I don't know how many people experienced that, but I did growing up because we grew up in the country. If one of the people in the party line had their phone off the hook, so that signal was blocked, nobody else could make a call. Nobody could get a call because the phone signal wouldn't transfer past that block in the line. And it's the same with the opioids binding to the receptors in your brain. They stop or decrease your brain's ability to send that signal. So that's the reason why they use opioid medications, is because it blocks that signal from your nervous system. Another thing that opioids do is they release dopamine, and dopamine is one of the feel-good chemicals, one of the natural chemicals that our body makes, and that helps us feel better or feel good. As an aside, studies say that, people these days, or kids these days, that are online a lot, like with social media, where they're looking for likes, or there's Snapchats where they're looking for the snap to continue. When they see what they want, like somebody liked their picture, or when you see that somebody, laughed at your joke or whatever, that actually releases dopamine in our brains. And that dopamine actually can lead to addiction with screen time and social media. But dopamine, whatever the cause of the release, can also cause the addiction. So opioids cause a dopamine release, and that's one of the reasons why opioids are so addicting. Opioids are used for pain management, and they are in general used to treat moderate to severe pain, and that would be pain caused by acute source, like a trauma, a broken leg, or a surgery. They're also used for terminal cancer pain, and they're used in end-of-life care. When I went to pharmacy school in the first several years that I was practicing as a pharmacist, opioids were very commonly used for chronic pain management as well. Things have changed over time. We've learned a little bit. And so right now, opioid use in chronic pain management is considered controversial. And opinions, like I said, they've changed over time. And so they are used less now in chronic pain than in the late 90s when I first graduated from pharmacy school, or even the first probably 15, 20 years of my practice. But even still, with the decrease in opioid use for chronic pain, data from the National Health Statistics shows in 2021 that 22% of adults with chronic pain have used prescription opioids in the last 3 months. So even though we're decreasing the use in chronic pain, they are still definitely used for chronic pain, and almost a quarter of patients or people with chronic pain have had an opioid. There's other medical uses for opioids as well. Believe it or not, they do use opioids to treat severe diarrhea, especially in cases of people that have an ostomy or some sort of gastrointestinal surgery where they've had to have, part of their GI tract removed. So they'll use opioids to slow down the transit of food through the GI tract. They're also used in the immediate postoperative period, so like in recovery after surgery. Opioids also inhibit cough, so they are in cough suppressants, like we mentioned earlier, like Robitussin AC, that's Robitussin cough syrup with codeine in it. And then they're also given during surgeries or procedures for sedation. There are many risks and dangers of opioids, and we're just going to talk about some of them. What we're going to talk about certainly doesn't cover all of them, but it's a good broad overview. One thing we see a little bit here at St. Mark's, because we do have a NICU nursery, occasionally we will see babies that are born early or with a really low birth weight. And there's also what they call neonatal abstinence syndrome, and those are babies whose mothers were using an opioid, whether it was prescription or not, during pregnancy. Those babies were also using it, essentially, because they're connected to the mother's bloodstream. So when the baby's born, they can have withdrawal symptoms because they were dependent on that narcotic or opioid from being in utero. So it's real important, maybe not in this population of our, for Salt Lake County, for our audience. There we go. That's what I'm trying to say. Opioid use in pregnancy is probably not a significant issue, but culturally and in our society, it is a big issue. So it's something we should all be a little bit aware of. And if the pregnant woman does use a drug treatment program, it can help reduce the negative outcomes associated with opioid use. So if they go into treatment before they deliver, they can help reduce the risks of that opioid use during pregnancy. And if the person is unable to quit, and they know they're pregnant or they want to get pregnant, but they can't quit, there are treatment options available. You can go to a treatment center and get methadone or buprenorphine, which even though those are also addictive, they are safer and they're used as a treatment to get people off opioids. They would, it's a long process and there's a lot involved, but those medications are used and approved to help people get off opioids and to break the addiction. And so being in one of those treatment programs definitely improves your baby's health. Next, we're going to talk a little bit about the side effects and then the misuse of opioids. So in this slide, the blue side is common side effects. So opioids can cause drowsiness, they can cause confusion, they can cause nausea, they can cause constipation, and they can cause a little bit of euphoria, which is in part due to that release of dopamine that we talked about earlier, that feel-good chemical. That's normal side effects with normal use. Misuse of opioids can cause things like slow breathing and hypoxia, which results from the slow breathing, and that basically means you're not getting enough oxygen. And then because you're not getting enough oxygen, you can have brain damage, and that brain damage can lead to coma, and that coma can lead to death. There's things that people talk about with narcotics. There's one word that people talk about a lot is tolerance. Another word is dependence. And another word is addiction. So we're going to talk a little bit about what each of those words actually mean. So tolerance means that over time, a person needs more drug to feel the same effect. So tolerance develops with long-term use of opioids, and that's whether they're prescribed by a doctor or whether they're illicit. It doesn't matter. Tolerance doesn't care where they came from or why you're taking them. Tolerance is going to happen after a period of use. And that period of use can be maybe at a week for some people. And for other people, it can take longer to start developing tolerance. But some people have shown to have tolerance with as little as 7 days use. Another word associated with narcotics is dependence. And drug dependence occurs with repeated use, and it causes like a physical change to your body, to the neurons in your body. So the neurons are the pathway that sends a signal, those cells that respond to the opioid and do their thing, they actually change so they only function in a normal manner when that drug is present. So then if you stop taking the drug, that can cause a lot of physiological reactions. A lot of things can happen to your body. And that can range from mild to life-threatening. It could be anxiety, mood disturbances, nausea, vomiting, diarrhea, muscle twitching. It can cause tachycardia or rapid heart rate. It can cause high blood pressure or low blood pressure. And in some people, it also causes thoughts of suicide. And that's from drug dependence. And some people are able to get through that without medical intervention if it's just like a mild symptoms and mild dependence, so to speak. But other people require medical support to get through that dependence phase when they decide to stop taking the medication. Addiction is characterized as a chronic disease, and it's characterized by having compulsive or uncontrollable drug seeking and use despite harmful consequences and long-lasting changes. So when people are addicted, they can't control themselves around that drug. They need it, they're going to get it, they're going to take it, even though they know that it can cause harm. This addiction often results in harmful behaviors, and these harmful behaviors lead to other health effects such as HIV, hepatitis, and being addicted to an opioid medication actually puts you at a greater risk for violent crimes because of the need to get the medication. People get themselves in situations that maybe aren't the safest. So let's talk a little bit about withdrawal, but I'm gonna grab a little drink here, sorry. So withdrawal can occur within just a few hours of stopping the opioid, and symptoms of withdrawal can include bone and muscle pain. It can include diarrhea and vomiting. It can include severe cravings. It can include sleep problems. It can include cold flashes and goosebumps. And it can also include uncontrollable leg movements or kind of like not really seizure activity, but it resembles a seizure a little bit, but it's mainly in the extremities. Overdose can occur both with prescription and illicit drugs. And an overdose occurs when a person uses enough of the drug to cause a life-threatening symptom, such as hypoxia, or when their breathing slows way down or stops. And that loss of oxygen, again, causes damage to the brain and other organs, and that can result in coma, permanent brain damage, and even death. I'm just gonna talk a little bit about heroin, and you'll see why in a minute. So opioids and heroin are chemically very similar, and they produce a similar high. And in many places, heroin is actually cheaper and easier to get than prescription opioids, especially since the medical community has really decreased their opioid prescribing. And there's a statistic out there that says nearly 80% of heroin users report starting out with prescription opioids and misusing them before starting to use heroin. So overdose, which can occur from prescription medications or illicit opioids, can be treated if witnessed or caught in time. So it's important to call 911 immediately if you suspect someone has overdosed. Naloxone or Narcan can be used. So if it's available to administer, you can administer it yourself, or you can wait for the emergency personnel to arrive and they'll administer it. Another important thing in general is for all of us to learn basic life support, for all of us to be able to do CPR if necessary. This is just a little pictograph essentially of how to use the Narcan nasal spray. And there's a fair amount of people that do take opioid medications either for a chronic condition like cancer or something like that. And it's become more and more common for the doctors to prescribe Narcan for them to have at home, so a family member or caregiver can administer it if necessary. So this is just a little pictograph telling you how to use Narcan spray. So in opioid overdose emergencies, it's important to be able to recognize the symptoms and take quick action. So if you suspect someone is having an opioid overdose, you can administer the Narcan if it's available. And you also want to call 911 right away, because without knowing how much of an opioid they got or how much is bound to the receptors, a dose of Narcan might not be enough. It could be that they would need another dose or multiple doses depending on what they might have. So anyway, you can look at the pictures there, but basically it comes ready to go. You just peel it open, you take the device out, you just hold it between your thumb and fingers, you place the tip in a nostril, and then you just push the plunger in to release the dose into the patient's nose. Naloxone or Narcan works by binding to the opioid receptors, and it basically kicks the opioid drug off the receptor. So naloxone is stronger on the receptor. It has a stronger affinity, or it binds stronger, however you want to phrase that. And so if the person has opioids in their bloodstream and Narcan or naloxone in the bloodstream, the naloxone will push the opioid off the receptor and bind to the receptor. But that effect doesn't last forever. The Narcan won't stay on the receptor forever. So it's extremely important to get emergency services involved if you do administer Narcan. Utah currently has a law that says Utah pharmacists can dispense naloxone without a prescription to anybody who might be at risk of an overdose, or anyone who's in a position to assist somebody at risk for an overdose. And this was a new law in December 2016. So if you have a family member or someone that you're close to that you feel might be a risk, you could actually get some Narcan and keep it on hand if you felt it was necessary. Just going to talk a little bit about some opioid statistics. So in 2019, more than 130 people died per day just in the United States from overdosing on opioids. In 2020, this number increased to 252 people dying per day due to opioid overdose. The Centers for Disease Control and Prevention estimates the total economic burden of prescription opioid misuse in the US alone. So we're talking just from the prescriptions, not even the illicit drugs. Opioid abuse or overuse or misuse, whatever you want to call it, costs us $75.5 million a year. This includes the cost of healthcare, the lost productivity, the addiction treatment, and then the criminal justice system involvement and all of that. So in Utah, I'm sure you've probably seen billboards about, let's say, things like Stop the Opidemic and Naloxone saves lives. So let's just talk a little bit about what we know about the opioid crisis. So again, 21 to 29% of patients prescribed opioids for chronic pain misuse them. 8 to 12% of the people with opioids prescribed for them develop an opioid use disorder. And then according to the CDC, anywhere from 4 to 6% of people who misuse opioids transition to heroin. So not every heroin user started out taking opioid prescriptions, and obviously not every person who takes opioid prescription ends up transitioning to heroin, but up to 6% of people that started out with a prescription opioid transition to heroin, according to the CDC. So I have a little bit of data. It was from 2016 to 2017, and we were on an increase of opioid overdoses at that point. And if you look at the graph down in the corner, that goes up to 2020, and you can see that the pandemic really, for whatever reason, and I'm sure it's extremely multifactorial, you'll see from the pandemic on, the amount of overdose deaths due to opioids, whether they're natural, synthetic, illicit, prescribed, it doesn't matter. This is all the data combined. You'll see that our death rate has the number of deaths has increased significantly. So even though the amount of prescribing is down and there's a lot more information and a lot more education, we are still in the middle of an opioid epidemic with increasing death rates. This is from 2017, so we'll just kind of skip that. This is some Utah specific data, and it's the data, the most recent data isn't available, but in 2016 in Utah, we had 466 opioid related overdose deaths, which is a rate of 16.4 deaths per 100,000 people, which is above the national average of 13.3 deaths per 100,000 people. And the numbers here in Utah have increased, and we'll see that on the next slide. And wow, I'm sorry, the slide is really busy. So we'll just talk a little bit about it. So as far as who's dying from a drug overdose, 63% of the people are male and 37% are female. And if you look at it based on what drugs were identified as the cause of death, any opioid, so doesn't matter where, any opioid is responsible for 75% of the deaths. Prescription opioids were responsible for close to 50%. Methamphetamine looks like it's about the same amount as a prescription opioids. Heroin is looks like maybe about 30%, and the same with benzodiazepines, which is like Valium and Xanax, lorazepam. And then down towards the bottom in the middle there, we can talk about how many drug deaths occurred by month. And really, it's pretty steady throughout. Looks like May was the lowest month with only 30, but almost every month had 40 or more deaths due to overdose of opioids. Interestingly enough, according to the CDC data here in Utah, 81% of the people who died from a drug overdose had at least one potential opportunity to get care prior to death. So there is help out there. The difficulty is getting it not only when it's needed, but when the person is in the right frame of mind and willing and able to seek help. All right, so we'll move on from that depressing information. So knowledge is power, and what can we do? One important thing we can do is to properly dispose of medications that are no longer needed. So if you had a total hip or a total knee and they sent you home with 30 Lortab and you use 2 of them and you've got that bottle sitting around because, well, you might need it, really the best thing to do is to dispose of it properly. It protects you, it protects any of your visitors, it protects your grandkids. It just takes it out of the equation so it's not there as a temptation or a curiosity for anyone. Another thing we can do is consider using other available options for pain control first, before we go to the doctor and ask for opioids, or before we try the opioid. There's other things we can do first, and we'll talk about that a little bit farther on. Since one of the most important things we can do as an individual is to properly dispose of our medications when they're no longer needed, there are multiple resources that tell us how to do it. This particular slide is from FDA.gov, and the recommendation is if there is a drug take-back option available, to please use that. You can go to the DEA website, your local drugstore, or local police stations, and most of them either have a specific day of the week or the month where they do it. Some of them have big metal bins available and you can just leave it, dispose of it there. And others, have annual events or whatever. But if you don't have a drug take-back option readily available, you can check the FDA flush list, and that's again at fda.gov website. And if it's on the flush list, which actually is almost all of the narcotics are on that flush list, you can literally just flush them down the toilet. And then you would want to scratch out any information on your label that can identify what it was or where it came from. And then you can just dispose of the label in your garbage. You can recycle the vial if that's an option, but you want to make sure that you remove any identifiable information. If that medication is not on the flush list, you can follow the instructions for disposing of it in the regular trash. And basically what they recommend is if you need to dispose it in your trash, you want to mix it with an unpleasant substance such as used coffee grounds or kitty litter or something like that. So you want to mix your pills in with that in a Ziploc bag, seal it all up, and then throw it in the trash. So now talking a little bit about what we can do instead of opioids or narcotics for pain. There's a well-known study. It was called the SPACE clinical trial. And they basically studied the effects of opioid versus non-opioid medications for pain, for chronic back pain, for hip or knee pain due to arthritis. So the study found that there was no significant difference between the opioid group and the non-opioid group over a 12-month period. The non-opioid group reported that they had lower pain intensity scores over 12 months, and the opioid group actually reported more adverse medication related. So what are some non-opioid medications? Acetaminophen or Tylenol is one of them. It has fever reducing properties, but it's also good for pain. Another category is non-steroidal anti-inflammatories, which are items like ibuprofen or naproxen or Celebrex. There's also gabinoids, which are now in many states considered a controlled substance. They are not opioids, but they do have a potential for dependence. And those medications work on pain receptors that aren't opioid receptors, because there's actually 4 different pain receptors in the body. So the gabinoids work on the non-opioid ones. Examples of gabinoids would be gabapentin or Lyrica, or pregabalin would be the generic name of Lyrica. There's also regional anesthesia. You might be familiar with getting a steroid shot in your knee, or I had one in my low back once. So it's effective use for specific times or problems, like if you have a herniated disc or something. So, and those have, they also use them in surgery. Like if you have a total hip, they might do spinal anesthesia or a block, quote unquote, and they use that for the immediate postoperative pain, and then they would have you take maybe non-steroidal like naproxen and some Tylenol, and then maybe send you home with a narcotic for you to use only if you really need it in severe pain instances. So there's also non-pharmacologic pain management strategies, or things we can do that aren't taking medications. So if you have like an acute illness, you can use like vibration or massage. You can use cooling therapy. You can wrap it, so you immobilize it, like if you sprained your ankle or something. That's a physical method of pain relief. And then there's also what they call psychological methods, which is, you know, educating you about, or educating yourself about the cause of your pain, so you have an idea of what to expect. and all of that. There's also distraction. So some people like to listen to music or, read a book or whatever. And then there's relaxation techniques like pain. Excuse me, I'm sorry. A lot of times exercise, like physical therapy exercise, is really very beneficial for pain management. Sometimes immobilization, again, is what they do. Like they'll brace it or put it in a sling or whatever. Massage, heat, cold, all of those things can help. There's also electroanalgesia, often or more commonly known as TENS, which can help. And again, we have the same psychological methods essentially for all types of pain. You can use education, distraction, relaxation, hypnosis, those types of things. For trauma, they often recommend RICE, which stands for rest, ice, compression, and elevation. So, if you sprained your ankle or wrist, you would want to rest it. You want to use ice immediately. You want to wrap it, and you want to keep it elevated. There's also things like for obstetric pain, they use massage a lot or pressure points. There's a fair number of people who like acupressure and acupuncture. There are all sorts of things we can do to help manage pain that don't involve medication, and that in studies show to be just as effective or perhaps even more effective than taking a pill for our ill, as they say. So I just have a cute little picture here of some stacked racks we can meditate on, or here's a dog giving his buddy a massage. These are all things that we can do to help manage our pain, especially for chronic pain. It's really important to have coping mechanisms and additional things that you can do to help manage the pain. That's everything that I have right now. So if you have any questions or anything, I would be really happy to answer them for you right now.
You can either unmute yourself or put a question in the chat. I think we have one that says, any PCP can prescribe opiates, but what is the percent of PC that can prescribe Suboxone or similar drugs?
So Suboxone or similar drugs requires a special designation on their license. So they would have to do that continuing education and get certified to prescribe that. Special certification on their license for that.
And PC is like your primary care
provider, yeah.
Care provider, yeah.
Yeah.
Wait a second, see if we get any more questions.
Sure. I don't know whose picture of a dog that is, but it's really cute.
Now, Jeanette, have you seen an uptick in opioid abuse in older adults as well? Is there a lot of research on that or not as much?
So here in the hospital, most of my experience was with post-operative patients. And so there was definitely a slice of that population that was like chronic pain that had multiple back surgeries long-term. So definitely with chronic pain, you're much more likely to have been prescribed opioids because it was kind of the go-to up until fairly recently. But people right now, like people that get a knee or a hip replacement or something, they're often, they come in for the surgery without having had an opioid, and they discharge, with maybe a prescription for just a few, and a lot of people don't even use it. So I feel like there's a decrease overall. I think the increase that we've seen with the pandemic has been more of the hidden use, or you know what I mean? It's like not, yeah, so.
Chris Beller asks again, he says, what do you know of kratom being used to treat pain or to wean off opiates?
I'm not too familiar with that. There's not a lot of studies on it. I haven't looked for studies in about the last year and a half, but previous to that, there haven't really been any controlled clinical trials to prove whether it works or not. I know that there's discussion about it. Some people anecdotally say that it does have benefit. Also, since we're kind of on the topic of non-FDA approved medications or substances, people also, there's several people anecdotally who say that cannabis also is very effective for pain management and for, weaning off stronger medications. Again, there's not any published studies that support that, but here in Utah, now that they have it legalized for medical use, there are actually some studies going. So we might get some reliable data, I guess you could say.
All right, I'll give one more minute if anyone has any questions. All right, thank you so much, Jeanette. This was so good. It was such good information.
Oh, you're welcome.
So next week we're going to be having our very own Erica Thompson, and she's going to present the Living Well with Chronic Pain Self-Management workshop that she does. So you'll have to come back for that. And thanks, everybody.
Thank you. I hope you all enjoyed it.
We'll see you next time.
Thank you.